Today we'll be discussing about Laryngomalacia. Laryngomalacia is reported to be the most common cause of stridor in an infant. What causes laryngomalacia? It is a congenital disorder. You know that the larynx is divided into supraglottis, glottis, and subglottis. The supraglottis contains the epiglottis, ariepiglottic folds, the false cords, and the ventricle. Laryngomalacia occurs due to partial or complete collapse of the supraglottic structures during inspiration, leading to noisy breathing. It causes an inspiratory stridor. What causes this collapse of supraglottic structures? It is mainly due to some anatomical abnormalities. The epiglottis can be long, curled, omega shaped. The ariepiglottic folds are short and are tethered tightly onto the epiglottis. There can be redundant mucosa or submucosa that can fall into the airway. There will be a tall, narrow supraglottis with a deep intra-arytenoid cleft, and the epiglottis will fall into the airway, and also the mucosa can collapse into the airway. Because it occurs in infants, there is another pathophysiology that is said, that is, there is some neuromuscular immaturity. There is some immaturity of the laryngeal adductor reflex pathway. There is an incoordination of the arytenoid movements that causes the supraglottic collapse and the airway obstruction and stridor. What is the clinical presentation? The child presents immediately after birth or shortly after birth or within 2 to 3 weeks after birth. There will be characteristic high-pitched, fluttering, inspiratory stridor. There is another important clinical feature for the stridor, that is the stridor is variable. The stridor will be more when the child is active, crying, irritated, feeding, etc. When the child is at rest, not feeding, the stridor is less. The stridor will be more during supine position, that is, the child is lying on their back. The stridor will be less when the child is sleeping on the sides or on their stomach. It is because lying on their back means there is more chance of the supraglottic structures to collapse. The child can also have feeding difficulties like cough while feeding, refusing feeds, emesis, that is vomiting, choking episodes, etc. It is mainly because for children there is a suck, swallow, breathe sequence. So this coordination is lost due to the supraglottic collapse. This coordination is lost, so they will have a difficulty in feeding also. When you ask history of the child, you have to ask about the feeding history, the sleeping history. If the child is presenting to you in a later age group, you have to ask about the gain of weight, loss of weight, failure to thrive, etc. Also, children who are at more risk are children who are born prematurely, low birth weight children, and children who had some necessity for admission to the NICU, neonatal ICU, immediately after birth. You have to ask about all those history to the parent or the caretaker. Another important point of laryngomalacia stridor is the severity of stridor increases. Like from 6 to 9 months, the severity of stridor increases. And then the severity comes down and it almost always disappears by 2 years of age. That is another significance of the stridor of laryngomalacia. The diagnosis is mainly clinical. You have to examine the child properly. You have to examine the child in the sitting position, in the lying down, supine position, and also while the child is feeding. You have to look for any cyanosis, any suprasternal retraction, subcostal retraction, and in heart rate, any tachypnea. All this have to be examined. Also, you have to examine the oral cavity, nose, and the neck. Look for any cleft lip, cleft palate, micrognathia, glossoptosis. You have to see for any choanal patency, any choanal atresia, any stenosis of the pyriform aperture. All that has to be seen. Also, in the neck, you have to see for any neck masses, any neck nodes, any neck retractions, any hemangiomatous lesions. In children with beard-like hemangiomatous lesions, they can have occult airway hemangiomas also. So that has to be kept in mind. So the diagnosis confirmation is mainly by a flexible fiber optic laryngoscopy. You can insert it through the nose. The flexible scopy is most commonly recommended. And you can see the supraglottic collapse during inspiration. That is the pathophysiology. That pathophysiology is identified in the laryngoscopy, and we can confirm the diagnosis of laryngomalacia. In older children, there is some condition known as occult laryngomalacia or sleep exclusive laryngomalacia. That is, the child will have symptoms of laryngomalacia only when the child is sleeping. In such cases, we can do a polysomnography and also a drug-induced sleep endoscopy to identify the supraglottic collapse during the sleep. There are many congenital anomalies that can be associated with laryngomalacia. So the most common congenital anomaly is Down syndrome. Others are Peary-Robin sequence, Charge syndrome, 22q deletion syndrome. So you have to rule out if the child is having any other syndromes associated with laryngomalacia. There are a lot of classifications for laryngomalacia. I shall upload the classifications in the post. Morphological classifications, lot of classifications are there. Depending upon the morphology, that is where the collapse is happening more, there are different type of classification. Posterior collapse. Posterior collapse is mainly due to redundant ariepiglottic mucosa or an abundant cuneiform cartilage. Lateral collapse is due to foreshortened ariepiglottic folds, so it causes lateral collapse. And anterior collapse is mainly due to a epiglottic abnormality, that is omega-shaped epiglottis, and combined collapses can also occur. What is the treatment? So the laryngomalacia can be classified into mild, moderate, and severe to help with the treatment. The mild, moderate, severe classification is not based on the stridor; it is based on the obstruction symptoms and the feeding difficulties. In mild cases, that is, the child will be having stridor but no feeding difficulty. The child will be sleeping well. The suck, swallow, breathe sequence will be proper, and there won't be any hypoxia. The SpO2 in room air will be around 98% in these children. So in such children, you just have to reassure the parents and you have to observe the child. The child has to come for frequent visits and see that there is no weight loss or failure to thrive. All this has to be documented. In mild cases, you can ask the parent to feed the child in a sitting position and to birth the child properly and not to make the child lie down immediately after feeds. There should not be any associated congenital anomalies. If there are any associated congenital anomalies or any neurological anomalies like cerebral palsy, generalized hypotonia, epilepsy, seizure, congenital heart disease, septal defects, aortic or pulmonary stenosis, all these children will require further evaluation. So in mild stridor, without any other anomalies, child is well, feeding properly, the weight is good, no treatment is required, just observe the child. In moderate laryngomalacia, the child will have feeding difficulty. There will be stridor along with feeding difficulties. The child will have regurgitation, vomiting, choking episodes and all that. The child may refuse feed. In these children also, there won't be any hypoxia, but the SpO2 at room air can be around 96%. So in these children, you can give an anti-reflux medication. And 60% of the children with laryngomalacia will have a gastroesophageal reflux. That is mainly because due to laryngomalacia, there is upper airway obstruction. So there is negative intrathoracic pressure and there is reflux of the laryngeal secretions, gastroesophageal reflux causing laryngopharyngeal reflux. So when this reflux happens, the laryngeal tissues are exposed to gastric acid and the laryngeal tissues will become further edematous, further increasing the obstruction, further increasing the reflux. So it goes as a vicious cycle. Also, there are certain studies that show that due to this chronic reflux or due to laryngomalacia, there is reduced laryngeal sensation. So their swallowing reflex is also less. So this can also lead to choking episodes. And also due to, as I previously explained, there is some immaturity in the neuromuscular tone. So the vagal tone is immature. So these children can also have a very weak esophageal sphincter and lower esophageal motility. All this will add to the gastroesophageal reflux and laryngeal edema and stridor. So you can prescribe a PPI or anti-reflux medications for these children first 4 weeks and then observe how the child is responding. If required, the PPI can be continued for the 9 months. In moderate cases, you can give some, if the child is having regurgitation, aspiration, etc., slightly thickened fluids or breast milk you can give. Always feed the child in upright position only. These children also does not require any other treatments or any surgical treatments. If there are no other congenital anomalies, the children has to be observed for any loss of weight, any failure to thrive. It's because during laryngomalacia, there is airway obstruction. The child is putting in more effort to breathe. So the child can have a loss of weight. In such cases, further treatment is required. In severe laryngomalacia, the child will be having stridor and recurrent cyanosis, aspiration, choking episodes, and the SpO2 at room around only 86%. And if the child is having other associated congenital anomalies, etc., we will have to go for a surgical correction of the laryngomalacia. Also, in severe cases, due to chronic hypoxia, the child can develop a core pulmonale or pulmonary hypertension. And also, due to constant severe sternal retraction, the child can develop a pectus excavatum. For all these children, we will have to go for a surgical correction of the laryngomalacia. Only 20% of the total laryngomalacia presents in a severe stage. So what is the treatment that is done? We have to correct the cause. Surgical treatment is known as supraglottoplasty or ariepiglotoplasty. Before the procedure, in children with failure to thrive, children with cutaneous hemangiomas, children with history of any previous intubation in NICU and all that, we have to rule out other airway anomalies also. So in such children, you can go for an examination under general anesthesia, microlaryngoscopy and a bronchoscopy under general anesthesia. So the ideal situation is the child should be under anesthesia, but under a light level of anesthesia and should be spontaneously breathing to identify the supraglottic collapse. And also the laryngoscope should not be inserted too much into the larynx. It should be kept at the level of the vallecula. If it is introduced into the ventricle, you will not be able to identify the supraglottic collapse. You see for any other airway abnormalities also before you go for the surgery. We can go for endoscopic ariepiglotoplasty. It can be done cold steel, some depending upon the sender. You can use laser, coablator, etc. Each ariepiglottic fold is divided to release it from the edge of the epiglottis. And when the excessive redundant mucosa is excised, sometimes cuneiform cartilage can also be excised partially or completely. Epiglottopexy can also be done. In certain cases, just an incision over the ariepiglottic folds will be enough to release the tightening and the supraglottic collapse. We have to make sure that the mucosa between the two arytenoid folds should not be excised. The interarytenoid mucosa should not be excised because if we excise it, it can cause interarytenoid scarring, so that should be preserved. Usually, antibiotics or steroids are not required to treat laryngomalacia. The child with laryngomalacia is developing a respiratory infection. The stridor can be more severe and in such cases require immediate treatment. Post-operatively, if you think there is some amount of laryngeal edema, you can give a short course of steroids to control the laryngeal edema until the child becomes better. What is the differential diagnosis? The differential diagnosis can be vocal cord palsy. It can be unilateral or bilateral vocal cord palsy. Unilateral vocal cord palsy, the child will have a hoarse cry, hoarseness of voice. Bilateral vocal cord palsy usually have a biphasic stridor and usually require tracheostomy. Other differential diagnoses are subglottic stenosis or tracheomalacia. Though these two are known as synchronous airway lesions. So usually laryngomalacia can be associated with the tracheomalacia and subglottic stenosis. Tracheomalacia, usually the child will have an expiratory stridor. In subglottic stenosis, there will not be any positional change in the stridor. That the child will not be better if the child is sitting upright, etc. Other differential diagnoses, there can be any subglottic hemangioma, laryngeal papilloma. Laryngeal papilloma, child will have hoarseness of voice, vascular rings, any foreign body aspiration. So typical history will be there in all these cases. Vascular rings, if you're suspecting, you'll have to go for a CECT. To summarize, laryngomalacia, problem is supraglottic collapse, identified by flexible fiber optic laryngoscopy. The reason is omega-shaped epiglottis, redundant mucosa, and also some neuromuscular incoordination. Child presents immediately or shortly after birth. The stridor usually resolves by itself by 2 years. Mild and moderate cases, not much treatment is required. Observe the child and anti-reflex medications can be given. Severe cases require surgical correction. Supraglottoplasty or ariepiglotoplasty can be done. In children with associated congenital disorders have to be monitored carefully and most of the time surgical treatment is required.